Everybody, thank you so much for joining this WHO Africa media briefing, which takes place in collaboration with the APO group. I'm Tsipiso Magwetla, your moderator. Thank you so much for being with us. Today we're going to be looking at the latest news on COVID-19 vaccines. As I'm sure you've seen, there's been a lot of buzz around it. So just some house rules quickly. Remember that you must indicate if you'd like to ask a question live. We have facilities for doing so. So please just indicate and use the Q&A section to pose your question. Please introduce yourself and your organization, and also let us know to whom you'd like to pose your question. Front right, you could please translate for me in French, including the fact that we are simulcasting in both English and French, so please go to the globe icon at the bottom of your Zoom app and select your preference now.
Bonjour à tous et merci de vous être connectés pour ce briefing. Si vous souhaitez entendre la conférence en français, vous pouvez aller dans l'option d'interprétation qui est disponible sur Zoom, le globe, et cliquer sur français. Pour poser vos questions, merci d'utiliser la fonction Q&A ou questions et réponses de Zoom en précisant votre nom et votre média, et également si vous souhaitez que nous prenions votre question en live. Merci à tous et bon briefing.
All right, thank you very much, Francois. So let me please introduce my panel this afternoon. Joining us from Brazzaville, the Republic of Congo, is Dr. Matshidiso Moeti, who, as you know, is the WHO Regional Director for Africa. She is joined by WHO Africa immunization expert, Dr. Richard Mihigo. From Johannesburg, South Africa, is Professor Helen Rees. She is Executive Director, Wits Reproductive Health and HIV Institute at the University of Witwatersrand. She's also chairperson of the African Regional Immunization Technical Advisory Group and chairperson of the South African Health Products Regulatory Authority. Also joining us is Professor Pontiano Kalibu, who's Director, Uganda Virus Research Institute and MRC UVRI and London School of Hygiene and Tropical Medicine, Uganda Research Unit. He obviously joins us from Kampala, Uganda. Welcome, and welcome to you as well, Professor Frederick Were, Perinatal and Neonatal Medicine, University of Nairobi, and Chief Research Scientist at Kenya Pediatric Research Consortium. He is in Nairobi. So let's start with the discussion. I'm going to turn to you, Dr. Moeti. If you could just tell us what the latest news is on COVID-19 vaccines and where Africa stands.
Good afternoon, bonjour, and thank you all for having joined us today to talk about COVID-19 vaccine readiness in the African region, and to say a warm hello and welcome to colleagues and friends. I hope Helen will be joining us soon, Professor Helen Rees, but hello to Professor Pontiano Kalibu and Professor Frederick Were. Thank you so much for having taken the time to join this conversation today.
I'm here with you.
With 3 COVID-19 vaccine candidates demonstrating high levels of efficacy, many countries are keen and determined to get the vaccine on time. We do know that African countries are concerned and hoping that pre-ordering of millions of doses of vaccine by wealthy countries will not disadvantage their accessing supplies. I think this is very much the issue of today that's being discussed all over, especially in the region. Vaccination in combination with tried and tested public health measures will help end this pandemic. And as the COVID-19 vaccine is rolled out in phases, it'll turn into the biggest vaccination drive in the history of the continent and indeed the history of the world. At WHO, we're working with countries and partners to prepare for this unprecedented initiative. And 40 African countries, we have 47 countries in our region, have shared data with us assessing their readiness. So we sent them a readiness assessment tool, and I'm really glad that most countries have relatively quickly started to use it and provide us with the data. And what we see is that so far, The average readiness score is 33%, which is well below the desired benchmark of 80%. So we are doubling down on planning and preparation because this will make or break this unprecedented endeavor. In our region, we're assisting countries to develop their COVID-19 vaccine introduction plans, including by leveraging our vast network of polio and immunization and other public health staff on the ground under the leadership of our WHO representatives. So we have physical presence in all the countries in the region, and these teams have started to work hard on this. And I had the opportunity to brief all the ministers of health when we had a meeting with them 2 days ago. We know that communities have played an incredibly important and central role in stopping the spread of COVID-19, and they'll be central in the rollout of the vaccines. It is critical that authorities reach out to communities, listen to their concerns, and give people a voice in the process of developing and implementing the delivery strategies. It's also critical to fight against false anti-vaccine information. So here I'd like to ask for your help, dear colleagues, journalists, to make sure that in the coming months, the vaccine narrative continuously emphasizes equity. We've promised Africa's ministers of health to do all that we can to ensure countries in the region are not left behind in the race to deploy vaccines, and I ask for your support on this. There are also key logistical and financing gaps where international solidarity will be imperative. The promise of vaccines comes as Africa reports more than 2.1 million COVID-19 cases and 50,000 people have sadly lost their lives. We've had a plateauing of the number of new cases per day, but we are starting to see an uptick, and that gives us a lot of concern. Countries in the Northern Hemisphere, including in North Africa, are reporting high daily cases as they move into their colder months. This is similar to what we saw at the beginning of the pandemic. And as I was saying, here in the region, the curve is once again trending upwards a little bit as we head into the holiday season when people will travel. It's vital, therefore, that we continue practicing the preventive measures and that scaled up proactive public health capacities are in place to flatten the rise in cases. At WHO, we're working with UN agencies and other partners at country level to provide support in this endeavor, including around the response to the pandemic and providing essential services for health, because we don't want this to suffer as we focus on COVID-19. So I look very much forward to our conversation today, and I thank you all for having joined us.
Thank you so much, Dr. Mweti. And just a reminder once again to my colleagues that should you wish to pose a question live, just indicate so and we'll be able to assist you. So now let's hear from Professor Helen Rees. It would be lovely to get your insights specifically with regards to various COVID-19 vaccines that are showing promise. Professor Rees, welcome.
Thank you very much. Thank you very much for the introduction and for inviting me to be on this discussion. And I think it's really excellent to have discussions like this because the data is changing so quickly. So I was asked to talk about the pros and cons of different vaccines and what would make decisions be appropriate for us in the African region and for other parts of the world, considerations that they might be looking at. First of all, I think it's clear that the first thing that you need to have is an effective vaccine and a safe vaccine. And the good news is that early results from 3 vaccines now, the Pfizer vaccine, Moderna, and the AstraZeneca vaccine have all started to show really exciting and promising results. So that's good, and they all look like they're safe at this interim stage of analysis. All of these vaccines, once we see that level of effectiveness and safety, even though the trials will continue, are likely to apply for an emergency use, either through the FDA or the European Union. And then later on with respective national regulatory authorities. So what are the things that we would be thinking about as we consider the characteristics of these vaccines? Well, the first thing is very practical things like how many doses do we have to give? Is it 1 dose or 2 doses, and how far apart? And can a program sustain that? The thing that's actually gained a lot of attention and discussion recently has been what's called the ultra cold chain with the RNA vaccines, in particular the Pfizer vaccine that requires at the moment a -70. Pfizer are working on this to try and change that parameter of the vaccine and make it more program friendly, but that's what it is at the moment. And clearly for the African region to have a widespread rollout of something that requires that kind of capacity in the cold chain would be very challenging indeed. The third thing would be, what do we know about the effectiveness? We heard that for the AstraZeneca, the overall effectiveness was about 62%. But when they looked at a lower dose, lower first dose, and a boost, which was the full dose, they went up to 90%. But effectiveness is efficacy from these trials rather is going to be very important. And as I said, safety. But we're also going to be looking at things like, do these particular vaccines work in particular groups? So given that the elderly older people over 60 go up quite quickly in terms of risk, how effective is any one vaccine versus another in that age group? Because we do know that vaccine efficacy wanes with many vaccines as people get older. Now, that, on the other hand, might be a bigger consideration if you have a population with a large number of older people. And it might be less of a consideration, for example, in the African region, where we might say, actually, even if we've got lower efficacy in that age group, what we really want to do is target this group, which is somewhat different because our demography is different and our economic profile is different. All of these things will need to be weighed up. And then clearly, for our region, the issue of cost. So the newer vaccines, these mRNA vaccines, are much more expensive when we compare it to, say, the AstraZeneca vaccine, which is a more established type of vaccine platform. So cost is going to come in, notwithstanding the excellent work that's happening through the COVAX facility. But for countries that are doing bilateral negotiations, cost will be a factor, and even through the COVAX facility, cost will be a factor. But the encouraging statements that many companies are making about public health pricing is really great news. I'll just briefly mention vaccine hesitancy, which is something that is also gaining a lot of attention because a lot of misinformation is going out there. For the African region, we had a problem right at the beginning of the pandemic, where unfortunately 2 French doctors had a conversation that went viral, where they appeared to be saying it's a good idea to come to Africa to do clinical trial research because we will have a big problem. And that was perceived as perhaps the African region being looked at as guinea pigs. And that created a very negative dialogue in our region, in some countries in particular. So since then, we've had, I think many of you will have seen a lot of misinformation coming out in social media, etc. And the mainstream media really trying their best to give accurate and complete information. And that's what we have to keep doing. So there have been a number of surveys now. One was published in Nature Medicine, which showed overall about just over 2/3 of people said that they would feel that they would like to have a vaccine or they would be willing to have a vaccine. But some people still being very reluctant to the extent of refusing it. That's about 1/3, and that was global. Very different figures from different countries, and men being less willing than women overall in that survey, and people who had more education being more willing than those who had access to lower education levels. So all of these things will have to be taken into account. And as we think about vaccine hesitancy, and that's why this dialogue is really, really important, we should really think about, what is the message that what would communities want to hear from us? the first thing I would say is we're going to have to break those communities down into different types. So we're going to have to think about who are our communities, who are our populations. Do we have the same message for older people who from that survey appear more willing to have a vaccine, and the same message for younger people who we know from their sort of behavior all around the world, it's quite easy for them to feel that they're going to be minimally exposed and minimally sick. So do they want a vaccine? What message do we give for these different populations? In many countries in our region, for example, we haven't ever targeted older people before. How do we target them and say, this is something new, we now want you to be immunized? What is the message there? And the important thing in that messaging will be to be very transparent about what we know about the vaccines, what we know about safety and efficacy, when the vaccine needs to be had, and also why we want people to be vaccinated and why it's so important to build up the population protection. But early on, one other message that will be complex to get out when we have limited amounts of vaccines, this will be a worldwide issue, is why are we targeting some groups and not targeting other groups? That explanation will also be very important. I'll stop there. Thank you.
Thank you very much, Professor Rees. Very interesting to hear that perspective, and I'm sure there'll be quite a few questions coming out of that. So let's move on now to Professor Pontiano Kalibu. Now, you're going to talk about the COVID vaccine clinical trials in Africa, the vaccine pipeline, and also, if you can, just tell us about how Kenya is preparing to roll out the COVID-19 vaccine.
Thank you very much. I think the last one for Kenya will be for my colleague Frederick.
Yes.
We'll talk about Kenya. But as far as vaccines in Africa is concerned, first of all, the vaccine pipeline. I think COVID allowed the vaccine research community to roll out a number of vaccine candidates, but using platforms which had been used in other infections, but good enough, some have really advanced into human clinical trials. I think the pipeline moves from inactivated vaccines, live attenuated vaccines, non-replicating vectors, such as the chimp adeno, which we'll talk about, replicating viral vectors, using them as vectors to carry the vaccine components. The RNA vaccines, very exciting, which two of them have come now to be efficacious, messenger RNA, DNA vaccines, protein subunit vaccines, virus-like particles. So we have a number of pipeline of vaccines, and some of them have moved into human trials. As we speak now, I think approximately 35 vaccine candidates have gone into human trials. And I'm happy to say that Africa is making a contribution, especially South Africa. South Africa, as you know, has had the highest number of COVID infections, but also now has the highest number of trials that are being conducted in the phase 3. The earlier one using the AstraZeneca, the chimp adeno, which the Oxford group, which has shown some efficacy, and I hope the trials will continue in spite of this, so that we can have the full trial completed to really know how good this vaccine is. South Africa is also conducting another phase 3 trial using a recombinant approach, which is developed by Novavax company, and it's in the phase 3. And the last one in the South Africa is using the adeno 26 with Johnson & Johnson. We have had a lot of experience with the adeno 26 in Ebola vaccine trials. We are using it here in Uganda for Ebola. So some of these vectors, like the chimp adeno of Oxford and the ad 26 are not new vectors. They have been used. So that gives us some I think, confidence that these are not completely new vectors that are being used. So 3 trials in South Africa. Kenya recently started also to be part of the Oxford vaccine trial using the chimpo adeno. That's the AstraZeneca, again as a phase 3, and I hope those trials will continue. For us here in Uganda, we haven't started our trial, but we want to go into a phase 1 trial using a self-amplifying RNA vaccine. And the plans are ongoing. We have delayed just because we want to really get the right doses that we need to use. But otherwise, we have had some preparatory studies going out to the communities to understand what knowledge do they have about vaccines, how acceptable vaccines are, especially in health, among health workers. And we're very excited to see that there was a lot of interest in participation in vaccine trials. Of course, now we know that with the results that have come out, 3 vaccines that have shown quite a good efficacy in terms of protection, how this is going to affect the vaccine pipeline and trials that are being planned. We, WHO and others, Africa CDC, we have been working together on the solidarity trials, adaptive trials, where new vaccine constructs will be introduced and test their efficacy. How the new results are going to affect the design of the solidarity studies needs to be discussed, and will be interesting how this will affect. Do we go ahead with all the trials we had planned? The trials will need to be bigger because now we have vaccines that are working. If they're introduced into the vaccine design, definitely that is going to affect the way we conduct additional trials. My feeling is that although we have these vaccines that are effective, appear to be effective, and as Dr. Mweta has mentioned, the plans to roll them out, this should not stop the research and development of newer vaccines. We don't know yet how long the immunity will last for these vaccines that are coming on. So there's a lot that we need to understand. Some of them, as you have heard, they need very cold storage, -70, -80. So newer products could come on that could be effective and easier to distribute. So I think the research and the trials should at the same time go ahead, although they will be more complicated and they will need larger trials because we already have a few vaccines that are proving to be effective. So I can say Africa is participating and will continue to participate in these studies. Of course, we'll be adaptive to the new results that we get as they come along. I think will not be surprised if we get additional exciting results that come on, and we'll continue to discuss how we design these studies. But otherwise, Africa is beginning to contribute, and interestingly, and which is good enough, there is acceptance of vaccine studies and vaccine trials. There's challenges ahead, but I think we are making a contribution. Thank you.
Thank you so much, Professor Karibu, much appreciated. I'm going to now to speak a little bit more specifically about Kenya to Professor Frederick Were. If I could just ask you, if you can, Professor Were, to just take 5 minutes so that at 1:30 exactly, 12:30 my time, 11:30, I think Brazzaville time, we can start taking questions.
Thank you very much, and good morning, Helen. I haven't seen you for a while, except here. In addition to the nice introductory remarks made, I also am the chair of the NITAG of Kenya. I could say a word or two about the preparedness. I'm not certain about what was sent to WHO in terms of our percentage preparedness, whether it's on that, whichever side of 30, but we are having a full weekend meeting beginning tomorrow as a NITAG to hear that from the ministry. What I can say is that at political level, at administration health systems level, at the department in the ministry level, I think there's been a lot of movement for us preparedness. The conversation that has been available at really all levels, I think despite not knowing the exact percentages, that has remained on our lips. We were in advanced stages of expanding our primary schedule to include 2 new antigens, which is, I think, the second polio injectable and probably conjugate typhoid. Those are some of the maneuvers we shall be speaking about, what we can stagger and go on, what must be done. Having said that, we generally have a fairly resilient immunization health system in cold chain, but it's not resilient in terms of those demanding -70. That's one end that we would be in a bit of trouble here if we have to implement. Another issue that is of importance in Kenya, probably a few other African countries, is that when we will be defining the categories of risk and those we must react to first, in this country, in the last 5 or so years, the population of over 60, which is what we regard here as the elderly high risk, it might be defined differently elsewhere, has actually now surpassed about cohort. So we have more than 1.5 million out of a total population of 44 that's now over 60. So even if we narrow down to the most at risk, the health worker population may not be as large, but if you look at all the frontline people who work in health facilities, it's also significant. So we will be maneuvering ourselves in the next couple of days how to define the sequence in which we should do the vaccination as the actual products come in. And importantly, we will have to be careful about which one we choose if they're both available, because my view is that one that requires -70 will not go far enough into the labyrinth of the health systems regarding immunization. But politically, I think I can assure people that the innuendo I'm hearing that people are ready, administratively in the ministry, we are prepared. The systems, the advisories will be coming out by the end of this weekend. And at least we qualify in Kenya and most other countries to benefit from the Gavi support, which brings, I think, the cost down probably $2 per dose, slightly less than that. So we haven't got where we want yet, but we have given ourselves maybe the next couple of weeks to make sure that we define our capacity to absorb and deploy the vaccines when they become available. I think I can leave it there for the moment and hear other questions. I don't have an exact answer to what percentage of the population, but if we repeat this conversation on Monday, Tuesday, I'll have had full feedback from the immunization program, which is happening tomorrow and Saturday. But I've been aware that we have been active in preparing. The moment we started hearing the vaccines are in the advanced stages, conversations have gone on administratively. Now they're coming to the advisory level beginning this weekend. Thank you.
Thank you so much, Professor Were. So it's time now for the Q&A section of this discussion. A reminder to my colleagues once again that if you'd like to ask a question live, you're more than welcome to do so. And please indicate to whom you're posing the question. Also introduce yourself. Don't forget to do that, including your organization. So we're also going to be able to answer questions in both English and French. So if you'd like to ask a question live in French, we do have interpreters, but also we will be able to have it interpreted if you're not asking it live. So let's go to the first question. I'm going to make sure that Kate Bartlett is available. She's from German Press Association. Kate, are you able to ask your question now?
Yes, can you hear me?
Yes, we can. Please go ahead.
Okay, hi, thanks very much. I have a question, I guess, for Dr. Moeti, but anybody else who has an answer. Firstly, when do you expect the first African countries to get a vaccine through the COVAX platform? And second, given the issues of cold storage for the 3 vaccines that have become available, how do you envision the vaccination campaigns working in some African countries? Thank you.
Thank you, Kate. Dr. Mweti?
Yes, thank you for that question. I'll start to answer, and my colleague Richard Mihigo could perhaps supplement. Through the COVAX, we are aiming to have an initial supply of vaccines to cover 3% of the population, so the highest priority group to be covered. And we're expecting this will be healthcare workers and also, as has already been said, the most vulnerable group, which is the elderly. And the expectation or the plans of the platform are that some of these vaccines should start to become available late in the first quarter of next year. So progressively, we are expecting by the end of next year to have been able to provide vaccine to cover 20% of the population, and then think that what is being done by other partners, especially the Africa CDC, will cover some of the rest, but we'll still be working with countries in the COVAX platform on this. And then the question of the cold chain, I think my colleagues have already, in their introductory remarks, addressed partly this, that the Pfizer vaccine, which requires temperatures of minus 70 degrees, will indeed be a huge challenge for most of our countries to be able to provide the conditions to distribute countrywide. We think that the other vaccine, which is going to need minus 20 degrees, might be more feasible, but certainly the AstraZeneca vaccine, which, although it has a lower efficacy, but it's certainly sufficient to provide population immunity at 70%, is going to be stable at the kind of conditions where African countries do have the capacity to distribute it, so it doesn't need this ultra cold chain. So that's the situation as far as that is concerned. If you permit, Tsepiso, I'll see if Richard has any addition to say to this.
Yes, please. Dr.
Yeah,
Mihigo?
thank you very much, Dr. Moeti. I think we've addressed most of the issue raised. Just to add that as part of the preparatory activities that are currently being conducted, as you mentioned in your introductory remarks, I think we are assessing a certain number of preparedness parameters in different countries, and one of them is the cold chain and logistics system in the different countries. So though, as it was mentioned, the overall weighted preparedness is around 53%, but we have seen that in different pillars in the preparation that we are following in the different countries. So countries are at a very different stage in those areas, and in particular with regard to cold chain, with the pre-existing system that are already handling the routine vaccination. So there will probably be a need to adjust a bit some of these, and we are currently supporting member states to make sure that the gaps are identified, and then resources be mobilized to as much as possible to fill those gaps before the deployment of the vaccine can start. So thank you.
Okay, thank you, Dr. Mihigo. So let me move on to the next question, and it's from Falilia from France Info Afrique. So I'm going to ask Professor Rees and Professor Kalibo to attend to this one. So it's two questions. Does a vaccine have to be tested in Africa to be efficient for Africans? And if so, is the one from AstraZeneca that's been tested in South Africa? What are the results thereof? Perhaps Professor Rees, you can answer that one as well. And the other question is about the storage modalities of the vaccine. AstraZeneca seems to match that of Africa's environment, says Valilia. Can you please remind us, what are those modalities? And if this vaccine is really the only one for Africa, are there other vaccines that can be better suited with the continent's constraints? So Professor Rees, we'll start with you, and then Professor Kalibu, you can answer thereafter.
Thank you very much. Very good questions. So one of the things that we as African scientists and clinicians and policymakers have been arguing very strongly is that we really should be doing some of this vaccine research in the African region. The very good news about, for example, the Moderna vaccine, excellent news, but no trial sites in the African region. And in discussion with the company and in a WHO discussion, we were able to say, what are your plans? Do you have plans for coming into different populations? Clearly, many of these companies which have done big trials, for example, in the US, have had diverse populations integrated into them, but that isn't the same as looking at African populations who live in our settings, because there are many other things that can influence the way that a vaccine works. For example, coexisting other conditions like malaria, other conditions that affect the immune system that might be more common in our settings. So to answer you, the preference certainly would be to have at least some clinical trial sites in the African region. And for products that haven't been tested in that way, I think we would want to encourage the companies to think very rapidly about how they can rapidly do a study. And it wouldn't be the same doing the whole efficacy study again, but it would certainly be a study that would look at aspects of safety and the immunogenicity. Well, how does the immune response work? So certainly that's one issue. And then in terms of the AstraZeneca, the results that we saw did not include the South African results. About 2,000 participants were enrolled in South Africa. They didn't include it. Interestingly, when we went into the field in South Africa, it was as we were reaching our first wave. And in fact, we had very few what are called endpoints. So very few people actually developed COVID across both arms of the study. So they didn't include those results, but those results will be able to give us safety data and immunogenicity data.
Okay, thank you. So Professor Kalibu?
I think the issue of Africa has been well answered by Helen, but also to note that studying of these vaccines continues. Even as they're being rolled out, initially there will be a lot of information that will be collected, especially on safety, but also in the immune responses. So this information will continue. So it is desirable to do, and it will be nice to do some studies in Africa, but that's not a condition to really introduce vaccines in Africa. They can be tested elsewhere. But as Helen has mentioned, it will be desirable and nice to know how these vaccines fare in the African population. Sometimes vaccines behave differently. A very good example is BCG, which behaves differently in different populations. But this will continue to be studied. Storage is an important thing. One of the vaccines is stored at -70, another one -20, another one 2 to 4 degrees. But again, still, they will continue studying, is it possible to lower the temperature for the Moderna vaccine to lower the Pfizer vaccine, which is -70, to lower temperatures, or even the Moderna one? That will be continued. So, but it puts, because of the logistics challenges which have been mentioned, storage at -8. Even us in the labs who work in specialized labs, keeping a -70 freezer is not easy. Yeah, they're not easy to keep. They're expensive to run. They break down very easily. Temperatures will fall, so it's not easy. But you can imagine health centers in upcountry health centers in many of our countries, how this will work. Efforts have been made to use solar power and the rest to run fridges. How do you run a -80, -70? It's quite challenging, but it's, of course, for now, better than nothing. You rather look on logistics and save lives, but the lower the temperature a vaccine uses, definitely the better. and more will continue. I think more research and more improvements of these vaccines will continue. RNA, of course, the two vaccines that use very cold temperatures are using RNA. RNA is very delicate. Even in the labs, we use RNA, but it's very delicate. You need to use really cold temperatures. It's a new technology. The first time it's being used this widely in humans. We have to learn more, but definitely storage is going to be a challenge. Thank you.
Thank you, Professor Kalibu. Let's now move on to the next question that's being asked live by Alex Winning of Reuters. Alex, are you with us?
Yes, I think so. Can you hear me?
Yes, we can. Please go ahead and ask.
Great, thank you very much. So the first question is specifically about South Africa. Could Professor Rees or anyone else please speak specifically to South Africa's cold chain readiness, which may be higher than elsewhere on the continent? Could South Africa handle, for instance, the Pfizer candidate, which has to be stored at around -70? And then the second question is to any of the experts on the panel, which is a question about birth rates. And we've been looking at birth rates, around the world during the pandemic, and we're just interested to hear whether it's possible to identify any early trends in terms of how the pandemic has affected birth rates in Africa. If anyone has done any research on that or has any insights, we'd be grateful to hear them. Thank you.
Thank you so much. So let me start with you, Professor Rees. Dr. Moeti, if you would like to weigh in on that, please do, Dr. Mihigo. Anybody else who wants to talk about the birth rate, if there's been any studies done on any impact or trends that we've seen, as Alex said. So Dr. Moeti, let me start with you, or Professor Rees, and then I'll come to you, Dr. Moeti.
Thank you. So I'll look at the South African question, and could we manage the requirements of a Pfizer vaccine as they currently are? And as we heard, they are actually working on some changes that would allow a much more stable vaccine at different temperatures. So the answer is, and we have looked at this, is that the kind of requirement that you need would be, for example, in central academic teaching hospitals, where many of the ICUs are also concentrated. But beyond that, really not. Now, we could argue that actually that wouldn't be a bad idea, because that would give us some of the sort of highly exposed, this is where some of our sickest patients are, etc. And we could immunize the healthcare workers. But hand in hand with that, you also have to then say, is that your highest risk healthcare worker? Because actually, your healthcare workers now in sort of ICUs and in high risk centers, high risk and the most technologically advanced centers, they're tending to have access to the PPE that's required. The people that are not, once we get out, for example, in the Eastern Cape, where we have a major outbreak and a major surge at the moment, in many of the district hospitals there, PPE is inadequate and protection is inadequate. So the irony is that actually you might be having better protected people in those centers where you could store some vaccine, but you probably would need it in terms of healthcare workers, possibly to different categories. So very limited would be the answer. And certainly we're working obviously with our EPI program, our cold chain in the ordinary EPI program wouldn't be able to manage that.
Thank you, Professor Rees. Dr.
Okay, so that interesting question about birth rate trends. I think right now what I can say is that no, we're not aware of, and perhaps I can get my team who work on this to pull out what we have available as trend on trends on birth rates. What we do know is that as a result of the lockdowns, pretty quickly, access to family planning, for example, in some countries went down very significantly. So when was halved, or even the the gap was even more than that in some of the countries where we did manage to get some information coming back. And then also rather concerningly, access to antenatal services and even having a delivery carried out by a skilled birth attendant also went down. I mean, in general, this was part of the impact of the COVID-19 measures on essential services. I would think that we will start to see, so we are now, you know, the first cases in Africa occurred, really started in around March. So in the next few months is when we might start to see if there are shifts based on similar patterns from previous years. So I'm sure we'll be finding out soon in the next few months if there has been a change or not. But this is something that we can look up and we can get back in touch with you from colleagues who are dealing with this specifically.
Thank you, Dr. I think Professor Kalibu, you had wanted to say something.
Oh, no,
Right.
I think.
Oh,
I could add a word.
yes, go ahead, Professor Ware.
Yes, we may not have the precise data on the actual major changes on the birth cohort to expect, but we know from Kenya, for instance, that we have had a big rise in teenage pregnancies following the lockdown of schools and the people being at home. That fact, I think, is reported from really throughout the country. So, though we cannot give you the exact magnitude of change, it's clear that among the populations that were not expected to be getting into the maternal side of things, we're going to have more in beginning now, because we started the lockdown around about April. So we are counting our numbers. Every region has been reporting that when children were at home, there was an increased rate of young person pregnancy, quite often from non-planned means and within child abuse or sexual abuse. But we expect a higher number of babies here.
Right. So before I go to the next question, Professor Rees, did you want to jump in?
Yes, I mean, the answer is, I agree totally with what's been said, we don't know, but to complement what Fred said about behavior under a lockdown, I mean, one of the other things to think about is what are for those people using contraception, what technologies were they using? And in quite a lot of countries, the predominant contraceptive being used is an injectable progestin. And they have an effect on the woman's body, which means it takes quite a long time, a number of months, to return to fertility, just under ordinary circumstances, unlike those who would be on the pill, where you miss a few pills and fertility comes very quickly. So it's also going to be influenced at a country level for those using contraceptives, if they couldn't access, by which technology they were using.
Thank you so much, Professor Rees. So I've got a question here from Pamela Amunazo from BBC Africa. So it is in French. If I could please get the response from Dr. Moeti in French, and perhaps Dr. Mahigo, if you'd also like to weigh in on that. So the question is about the DRC, currently that there's talk of a second wave of contamination. What is the WHO planning with regards to helping the country, especially since the first wave had seriously affected the economy? And is WHO planning to do mass testing in countries like the DRC? Testing has not been done until now in order to know that the real number of people affected. Dr. Moeti?
Oui, merci pour cette question. Bon, effectivement, ce que nous voyons en RDC, c'est que le virus circule principalement à Kinshasa. Bon, il y a aussi des cas au nord Kivu et donc quelques autres provinces, mais la plupart des cas confirmés sont à Kinshasa. C'est vrai que vers septembre, ils ont reporté peut-être 12 cas par jour. Et en fait, notons que c'est un pays qui est très peuplé, donc le nombre de cas, nous notons le nombre de cas par population est assez bas. Ça restait toujours bas. Et au début, il y avait beaucoup de cas, c'était principalement à Kinshasa aussi. Donc, il y avait la transmission au niveau communautaire à Kinshasa. Ça s'est arrivé à peut-être 100, 200 cas par jour. Mais depuis le mois je peux dire quoi, maintenant, nous sommes arrivés à avoir 55, 45 cas par jour. Donc, c'est vrai que par rapport à ce qui s'est passé peut-être il y a 2 mois, nous voyons un nombre un peu plus élevé de cas. C'est principalement, comme j'avais dit, dans la ville de Kinshasa. La stratégie de dépistage en RDC a été toujours plutôt sur les malades qui manifestent la maladie. Donc, c'était un peu concentré là-dessous à Kinshasa. Il y a des plans au niveau du gouvernement de faire maintenant quelques enquêtes avec le kit de dépistage rapide. Ça peut permettre de savoir là où le virus est en train de circuler. Donc, je peux dire que par rapport à ce qui s'est passé il y a 3 mois, 2 mois et quelques, le nombre de cas quotidiens est élevé, mais nous trouvons que pour un pays avec la population de Kinshasa, ça ne peut pas être considéré comme une crise, sûr que nous devons, comme on dit, continuer à faire ce qu'il faut faire, améliorer le dépistage, et puis aussi le suivi de contact et l'isolation de ces personnes-là et l'utilisation de masques. Là, je crois qu'il y a beaucoup d'efforts à faire pour rappeler à la population que même si le nombre de cas n'est pas trop nombreux, il faut mettre en œuvre ces gestes barrières qui sont très, très importants. Merci.
Thank you, Dr. Mweti. I'm going to ask if my colleague Paul Adepo from Lancet and Devix is online. I believe you want to ask your question live. Paul, do we have you on? Paul?
Yes, I'm here. Can you hear me?
Yes, now we can. Please go ahead.
Yeah, thank you very much. So I have a question for Professor Rees. As an expert, considering the major stumbling blocks before the deployment of these vaccines, do you still think, looking at how Africa has gone in controlling the pandemic without the vaccine, what is the justification for still going ahead and investing heavily in procuring these vaccines that would only in the short term benefit a few proportion? I think Dr. Mweti said just 3% of the population. So for Dr. Mweti, I want to have an update on the rollout of RDTs for COVID-19 testing, which you mentioned a couple of weeks ago. And what is the current status? And how do you think Africans can actually rapidly have access to the COVID-19 vaccine? So thank you very much.
Thank you, Paul. Cerise?
Yes, and it's a question that we've actually discussed within the region. So it does appear that the nature of how the virus has behaved in the African region doesn't seem to be as it has behaved in Europe. Now, having said that, in South Africa, we're having a second wave in one of our poorest rural provinces. That's very significant and is approaching what the scale of the first wave. The second thing is that one of the arguments that's being put forward is, do we need a vaccine because so many people might have been affected, but asymptomatically they'll have antibodies. We've seen reports of levels of antibodies indicating past infection in 40%, 50% from, but sort of isolated serosurveys. But the answer to that is we have no idea what we need, what we will really need to have what's called herd immunity. So probably the estimate at the moment, and it's varied from the time the pandemic started from as low as 10% up to 80%. But the estimate that you'll see from modeling is probably between 50 and probably as much as 70% if we were to have herd immunity. And that's either from natural infection or from a vaccine. So we can't say with any certainty at all that because we might have had a high force of infection, particularly say in dense urban settings in our region, that that's going to mean that we're going to have very minor second waves. The second thing is the majority of people in many countries have still not been exposed to this virus. So what we're saying, and if you put the figures of how many people there are in the region, over 1 billion people in our region, you put those figures together and you say over time, pretty much everybody is likely, with some exceptions, the majority of the populations, if you do nothing, will be exposed to this virus, particularly if fatigue sets in and all the measures that we're encouraging people to use are not used. So if they're all exposed, even if you say, well, it's 20% that get sick, it's 5% who need hospitalization, and in our settings, it's sort of perhaps 2% or less than that die, that's an awful lot of people. And the economic disruption and the social disruption and the ongoing lockdown, lockup is going to cause havoc. So you have to weigh that and what we would have to do to contain a second wave. We're talking in South Africa at the moment about should we be doing more lockdown measures in the Eastern Cape and the Western Cape? What do we do to respond to this? If we keep doing this, the economies of our countries are really, really going to suffer. But the experts who are looking at this with all of those levels of uncertainty, despite the fact that I agree with you that it looks like we've had a different kind of epidemic in many of our countries, the vast majority of people are saying we definitely will need vaccines. Without that, we are going to go on seeing this massive disruption to our community.
Thank you, Professor Rees. And I wanted to mention earlier on that Johannesburg Hadidars always want to announce themselves. So I see you've got company there. Dr. Moeti?
Okay. Yes. Thanks very much. I mean, if one can add anything to Helen's excellent response, is to say in most African countries, the vaccine is circulating when it is circulating, mainly in urban areas, in the capital cities, and in the kind of centers of the economy. So as long as that is the case, even if we can say, well, a few elderly people can die because they had pre-existing conditions, which is also tragic if we multiply them in the countries. It is in the places where the economic activity is most vital in the countries that the virus is circulating. This just increases the risk, and our belief is that if there's a solution that can enable normal life to resume and the horrendous economic impact that is going to be with us for some time to start to be addressed, then we should absolutely take it on. The rollout of RDTs, as I indicated, WHO working with partners has been able to secure some significant supplies of rapid diagnostic tests, and WHO has also agreed to the emergency use licensing of a couple of reasonably well-performing rapid diagnostic tests. We see that increasingly countries are interested in using these, especially for cross-border testing of people who are traveling. And then we encouraged, as we said the last time, that they be very much used to confirm cases, confirm where the virus is circulating, to be able to get a better handle of the pattern of transmission, so that it can be possible to do the kind of thing that will enable the lockdown easing to continue, meaning to focus on local action where we see the virus is circulating among cases and contacts to contain the spread. I'm not able to give more precise figures of how many of the targeted number of distribution we have managed to carry out in WHO, but I know that we are working very much with our colleagues in headquarters and other partners on the distribution of these RDTs, and we'll be able to provide you, if we take note of who asked this question, with the information again from our team, which is not connected on this call because we mainly were expecting to be talking about vaccines, but this information will certainly be available with our logistics team in our incident management group. We can send it to you.
Thank you, Dr. Moeti. So we've got a question here from AFP, and I want to find out, Sophia Christensen, are you in a position to ask your question live? As in, would you like to do that? Sophia? Okay. If you do want to pipe up, I'll read your question so long. So it is directed to Dr. Moeti. It's about something that you mentioned earlier on, Dr. Moeti, this criteria. She's asking that you please elaborate a little bit more on the WHO criteria for vaccine readiness. The fact that you spoke about 80% ready when it's below a country threshold, what exactly does that mean?
Okay, thanks very much for that question. So I'll suggest that Richard provides the details of this aspect of the preparedness.
Okay, thank you, Dr. Moeti. Usually in any vaccination drive, there are a certain number of parameters that country puts in place and follow up to make sure that all the different pieces are together to have a successful vaccination campaign or introduction for any new product. So for this particular COVID-19 vaccine delivery, WHO, working with partners, particularly UNICEF, we've came up with a number of criteria and parameters, 10 in total, that is going to measure the level of preparedness of the country vis-a-vis the rollout of the vaccine. So these parameters range from planning and coordination aspect, regulatory readiness to make sure that the vaccine can be registered easily, supply chain, logistics and cold chain, communication, risk communication, community engagement, safety monitoring, etc. So all of these different parameters are followed up and can be scored in terms of readiness or not. So after looking at all of these different parameters, and experience have shown that when we have an average or weighted score around 80% or above, clearly it shows that the country can safely deploy a vaccine or conduct a vaccination campaign to reach the maximum of the impact. So we are far from getting there. So far the weighted average is around 33%, but we have different average when it comes to a particular pillar of the preparedness. And this is what I think Dr. Moeti stressed at the beginning, that we need absolutely to work and support country to make sure that the countries can bring up all of their different pillars of vaccine introduction to a level where if a vaccine becomes available soon, a country can safely deploy the vaccine to reach the maximum impact.
Thank you very much, Dr. Mahigu. Let's move on now to this question. Professor Wera, it's directed to you. How is Kenya prepared for vaccine? How's the situation in other countries? Is there already a certain number of doses saved for African countries? I think this is a more broader question, which can be answered by any of the panelists. Are European countries acting selfish on the cost of African countries when it comes to the vaccines? So let's start with the Kenya situation, and then Professor Kayu, maybe you would like to add to that, as well as you, Dr. Moeti, Professor Rees. Professor Wera, let's start with you on that question.
Yes, Kenya is I wouldn't say absolutely prepared, but Kenya is on the ready to advance the preparedness for a vaccine. And that's, remember, I mentioned in the beginning that in the next full weekend, the NITAG, can you hear me?
We can hear you, we just can't see you. I think video off. I think you may have switched the video off.
I'm trying to put it on, it's refusing. It won't agree.
I'm just going to ask the administrators to, okay, there you are. We should be able to see you now. Try again, Professor Lere. Okay, let's just allow you to talk, let me not.
Okay, let me talk. I was saying that the Kenyan system, I think, is preparing very aggressively and is sufficiently prepared in terms of cold chain, depending on what we do get as a vaccine that's available. And I believe that by the time Dr. Moeti mentioned it's the end of the first quarter of next year, there will be. We are going to spend the next 3-4 days largely discussing additional logistics, like who to begin with and mapping them out, and that sort of thing. Kenya has a unique system of having a national storage and a more distributed regional storage system that has the same cold chain capacity as the national, but not volume-wise. So the preparedness is probably better than many, but I can't say firmly today that we are fully prepared. But I can actually vouch that given the time between now and the beginning of next year, we shall be. And in the course of the weekend, we shall be busy just fine-tuning those sort of things.
So thank you, Professor. So we are running a little over because we have a high volume of questions, and we'd like to ensure that we get as many questions answered as possible. Professor, would you like to weigh in on some of those questions, especially around how the situation is in other countries with regard to vaccine readiness, and are there a certain number of doses saved for African countries, and obviously the race for vaccines?
I don't have much to say, only that to say state that many of African countries now, because the results have just come out for some of these candidate vaccines. Of course, there are some who are thinking that the vaccine will come out soon, but this is the time to prepare. I cannot give you how much like Uganda is prepared, but the discussions are beginning, just like in Kenya and elsewhere, to start talking about working, of course, with WHO. Dr. Moeti will have to chip in here, working with WHO and other partners to see how we can have access, and the distribution and the temperature chain. Most of us are not that ready, but I think the discussions are really beginning. And I would like to listen to Dr. Moeti and other partners that we're working with. Thank you.
Perhaps it's Helen here, if I may come in on the question of access, and have some countries got a lot, and have the Western countries got a lot, and are we going to get none? So I think there are three things I would want to say. Right at the outset, this was a major concern, and we look back at the pandemic flu in 2009, and we recognize for the African region that we got right at the outset was a major concern, and we look back at the.
You can go ahead, Professor Rees. There seems to be some gremlins in the system today. I really am not sure what's going on, but we can hear you.
No, as I say, if we look back at the pandemic flu, the African region got very little vaccine and very late. And had it been a higher mortality, we would have been really in trouble. So from the outset, we've said that we want equitable access for vaccines. And that was why the COVAX facility was established. And it's prioritizing 92 countries, which are called AMC countries, Advanced Marketing Commitment. And those are the countries. These are some of the less well-resourced countries that will have donor support, Gavi support, World Bank support to purchase vaccines. But in addition, self-financing countries are also putting money into this, and over 180 countries are now interested in that facility. So the COVAX facility, the idea is to try and get equitable access. So when we talk about that 3%, that's to say, can we get 3% to all countries of the world to begin with? But that's not the end game. The end game is obviously incrementally and as quickly as possible to go up. But I think that one question, and everyone has heard this, that many of the richer countries have purchased large billions of doses in some cases of vaccines. But some of the countries are now saying, well, if all these vaccines turn out to be successful, or at least many of them do, and we have too much, there is a discussion going on about whether those countries would be willing to put vaccine back into the system. The COVAX facility would be one way of doing it, bilateral agreements would be another. So I think all of this is moving very fast. But I think my third point is, and it's a point that's really worth saying again and again and again, that it's in nobody's interest to protect every citizen in one country and then leave many poorer countries without vaccine. Because you will never protect every citizen in one country with a vaccine. Many people won't be able to take it, won't want to take it, won't be accessed, and for various reasons. So you'll protect, even if you protect the majority, you'll still have vulnerable citizens. And B, as long as we have countries with large amounts of circulating virus, that virus is going to transport, as we've seen already. So it is in everyone's global interest to say, while we understand politicians are wanting to look after their own citizens, but actually to look after global citizens is the way that we're going to get on top of this virus. And I'm with my apologies, I have to jump off, but for all of the journalists, I'd be very happy through the WHO office if you wanted to ask any further questions. But
just before you go, Professor Rees, do you have just a sentence in wrapping what you would like to end off the discussion on?
Well, I think that we should regard vaccines in this current environment and more generally as one of the biggest global health goods that we have in the world. And they really need to be made available to everybody on as equitable and as fair a basis as we can. And this is the beginning of a very important discussion in terms of global health and setting new standards for how we regard each other across frontiers as global citizens. Thank you.
Thank you so much. So we're just going to get final comments, but before I do so, Dr. Moeti, there is a question for you from Francophone paper in, I think, in Dakar, Senegal. It's Radio Oxygène. Mbanik Diouf is asking the question. Will there be free vaccines for African countries? If you could please respond in French, Dr. Moeti.
Okay, I think free meaning will the countries have to pay themselves, or will people have to pay to be vaccinated? I think what just building on what Helen said in a little bit of detail about the COVAX mechanism, it includes low-income countries mainly, where there has been a contribution by donors of the money that will be needed from the procurement of the vaccine, but also the World Bank has made available a facility where the countries are also expected to obtain some of the funding and to pay the equivalent of what the self-financing countries are contributing. So it's subsidized very much based on international solidarity and contribution by some donor countries and donor organizations. But there's an expectation that now that some funding, $12 billion, have been made available by the World Bank, countries will go to the World Bank or find other means to obtain a certain proportion of the money that they are going to contribute. So I would say that it is highly subsidized as a solidarity mechanism and platform to enable African countries to start to have the vaccine right at the beginning, like every other country, but they are also expected to make some effort. And I can also add that the African Union, the Africa Centers for Disease Control, and a group of private sector partners, including the Exim Bank, are mobilizing funding to cover the rest of what the COVAX platform is not going to be able to cover. The COVAX platform is aiming to cover 20%, and we've heard many times from the Africa CDC that they would like to work with other partners to mobilize the funding so that we can relatively quickly get to 60% of coverage, at least to be able to have the funding to pay for that.
Thank you, Dr. Moeti. So we're just going to get final comments now, and Professor Were, I'm not sure if you're quite ready, but perhaps we'll just give you an opportunity to get yourself ready. Professor Kaliwe, there's a question that was sent by Sinwa News Agency earlier on by Naftali, who was asking really if you foresee any barriers that could derail the rollout of the vaccine.
In Kenya, yes, there will be barriers. We often battle antagonists who are there as a final remark, but we do have a method of some in-country testing to some degree to answer some of the fears which are usually around fertility. So whenever we have a new vaccine, we'll get it in and have it tested very quickly, and they assure the Catholic Church and any other antagonists that we are fine. Yes, in terms of the usual antagonists, we usually have that covered for every vaccine that is either new or coming for purposes of a campaign. Otherwise, my final remark would be that I think the Kenyan environment will work around the clock to meet the timelines that I had Dr. Moeti mentioning. And our local forces that propose vaccines, I think we have an SOP with them that we shall follow the same and we should get by. Thank you.
Thank you, Professor Were. Professor Kaliwe, if you could also answer that question, including this, if you could possibly shed more light on the vaccine that's currently being developed, any of them really, and if they will be in any way able to prevent infections or the spread of the virus across the globe.
Thank you very much. Is the question the vaccines being developed globally or in Uganda? What
I think it's globally, really. I think it's not necessarily specific to any one vaccine. The question is about if you could shed light on a new vaccine, but obviously there are quite a few, so you can be general about it.
Yes, yeah. Some of the vaccines that have shown efficacy are preventing infections, preventing new infections, and then there are others that are preventing severe disease. I think the Moderna one is preventing, the results so far, preventing severe disease, at least moving into severity, and the other two are preventing infection. Both are important because eventually we don't want, of course, people to get severe disease, but preferably if you can prevent infection, that will be most important. I think one other thing that a lot of now research needs to be done is to find out what is the correlate of this protection. What makes this vaccine work in terms of preventing the infection or disease, and then the vaccines can be improved on. So most of these vaccines are really aiming for that, either through infection, preventing infection, or moving to severe disease. The barriers, I think, what we've been talking about, finances. Always the financing is a challenge. We hope we can get the support, especially the low and middle income countries, to get the finances to have access, but also availability. There may be a demand, but also the production of these vaccines is not quick and simple. So whereas there's a demand on this side, the production side also has to be matching the demand. So I think where countries are producing, they have developed these vaccines, they need to accelerate. Of course, other countries like India and the rest are coming on to say, if we can have go through all the processes, we can contribute to the production of these vaccines. I think that would be very good. And one of my final remarks I want to say, I think it's an exciting time. The earlier discussions, press conferences we had, we're talking about the pandemic, concerned about how the pandemic is going to evolve, how are we going to manage, how are we going to treat, to prevent. It's good now we are beginning to talk about access to vaccine. It is, I think it has been amazing the speed at which science has moved on to this where we are now to have some vaccine candidates that are promising. And I'm sure a few more will come on. So I think we have to really be very proud of the science and the speed and the investment that has been put into all this. And we hope, we're excited. Next time we have a press conference of this kind, we'll be talking about how many countries are now ready, and maybe about the pandemic is really in a bad state, especially in the Europe and the USA and other countries. I think we need to, but we are a bit excited by these new developments, and we hope sometime by the end of next year, at least we'll have reached somewhere in the control of this pandemic. Thank you.
Thank you, Professor Kalibu. Dr. Mihiga, I'm going to come to you for final comments, and I wonder if you can comment on this at all. If it's a question from Graef from Civil Engineering Department, asking if there is a classification for vaccines, as in vaccines for different types of COVID. I wonder if it's something that has been in discussion or being looked at.
Well, thank you for the question. I think what we can say at this stage is that for the first time, different platforms, some of them are new, have been used in this search for a vaccine for COVID-19. For the moment, we have 5 different platforms. I think Professor Kalibu, in his introductory remarks, tried to explain that we're actually using for the development of some of these candidate vaccine. So having such diversified platform of technology to develop and a vaccine, I think it has been one of the amazing development for this particular pandemic. And we have seen the speed at which we have get to the products less than 1 year from the initiation of the clinical trial to the result, things that used to take several years. But what I would like really to stress here is the what WHO has been saying since day one. I think we will not compromise at all on the safety of these products, and particularly when it comes to providing any pre-qualification for these different programs. So WHO has really set up a very rigorous mechanism to evaluate these products, including what we have called a rolling submission process that some of these vaccine developers have been submitting data as they become available to make sure that the information can be at least assessed as it becomes available. So we are really at a very exciting moment. I would like to retain one sentence that Dr. Moeti said at the beginning. I think this, if we are not doing what's it required, this can be either to break or to make sure that things are going to work very well. So I think it's really an appeal through the media to our member states to accelerate the process of preparedness and readiness. We have a very short window for opportunity to make sure that countries are improving their preparedness and get ready when this vaccine will start to be rolling out, sooner, we hope, than expected in our region. So thank you very much, and over to you.
Thank you, Dr. Mahiga. So final comments from you, Dr. Mwiti, especially around preparedness.
Tsepiso. First, I'd like to join Pontiano in a very positive note. It's been a tremendous progress in a very short space of time. And we are ending the year, or we're going towards ending the year on a high note of hope and of expectation of having this effective tool of a vaccine, whatever type of vaccine we end up getting in the African region. So now going to the point made by Richard, which I would also like to underline, we must get on with the preparation now. For some of us, it might mean changes of our plans for having a break over Christmas. I think it is very, very important to speed up on the work of doing the preparation. Luckily, in many African countries, we are familiar with preparing to organize campaigns, vaccination campaigns. This is going to be different. It's not targeting, as we're often doing, under 5 children, but we will find ways to adjust and to be able to do that prioritization and targeting of people. My last word will be to say that at the same time, until we actually get the vaccine into the countries, get the vaccine out into the health services and into the people, we must continue with preventing what might be emerging as a ticking up of cases in the African region. So even as we are going into the festive season, please let's remember our public health interventions that have to be carried out at the individual level, and where luckily we have managed to build capacity now around the countries, including in at the subnational level in districts and provinces. Those systems have to be kept working as effectively as possible, even as we celebrate the fact that we will soon be rolling out a vaccine after very hard work in the next few months. So thank you. I'd like to end there.
Thank you very much, Dr. Mwiti. I think it's a very good note to end it on, wishing everybody well and safe, and hopefully it is a festive holiday period for you. And as Dr. Mwiti says, let's remember to keep safe during that. Please do enjoy the rest of your day, and thank you so much for joining us. This is the end of the briefing.